My institution, I, Dr. Charu Sachdeva, is highly obliged to the guests who have made it to the conference and would be presenting their papers in the later part of the event. To start the event, I would request Dr. Parveen Kaur, Head CCU Unit RGCIRC and President Critical Care Conference to welcome our audience.
Thank you, Dr. Charu. Good morning, everyone. I, on behalf of Onco Critical Care Society and Rajiv Gandhi Cancer Hospital, welcome all respected faculty members, delegates, and all of you for joining us so early in the morning. It gives me immense pleasure to welcome all the speakers who have come here to share their knowledge and vast experience with us. This conference in oncocritical care offers an excellent opportunity for delegates to engage with experts in the field. I welcome you all for this academic session. With this, let us start the program. And this year we are live on Zoom as well. So now I'll call upon Dr. Charu to take the program forward. Thank you so much for joining us.
Thank you, ma'am. IT team, can we have the screens on, please? The past several decades have witnessed the steady growth of large, multi-centric randomized clinical trials in critical care, designed to answer the important question that challenge us in daily clinical practice. To know more, we have Dr. Sachin Gupta, Director, Critical Care Narayana Super Speciality Hospital, who will showcase his recent clinical trials. I would request Dr. Kapil Chabda, Senior Consultant and Coordinator, Maharaja Agrasen Hospital, Punjabi Bagh, and Dr. Prashant Singh, Senior Consultant, Critical Care Medicine, RGCIRC, to chair the session.
So I welcome you all for this second Onco Critical Care Conference. And I'm privileged to chair this session, first session of this conference. So I would like to invite Dr. Sachin Gupta, who is Director of Critical Care, Narayana Super Specialty Hospital. His areas of interest are ultrasound in critical care, advanced hemodynamic monitoring, and extracorporeal therapies. He has been a chairperson, ISCCM Gurgaon branch, General Secretary elect, ISCCM, Associate Editor, IJCCM, Organizing Secretary of First Gurgaon Criticon, Coordinator Research Committee, ISCCM, North Zone Representative, ISCCM, Teacher and Examiner of various courses in CTCCM, IDCCM, and FCCU. He is co-editor of Ultrasound Manual in Critical Care, and he has authored many articles, chapters, and guidelines. So I welcome Dr. Sachin Gupta.
Thank you for the kind invite, and good morning all. And I would also like to thank Dr. Praveen and Dr. Saurabh for having me here. I was a part of the first event as well, and I'm privileged to be here again. So the topic I was given was 5 recent trials that changed my practice, and frankly speaking, it took a lot of time to decide what should I include and what should I exclude. Now, because the number was 5, so I decided not to touch older topics, and I tried to look at very recent ones. So see, there are roughly 20 important journals that we look at in critical care, respiratory care, internal medicine, which are directed towards acute care medicine. And almost 300 issues are published in one calendar year, and there would be roughly 6,000 research articles. 50% happen in animal labs, so let us exclude them. But what changes my practice? Around 25. So to crux that 25 is very, very difficult. So I've chosen only important 5, which I feel have not made me change my practice, but it has made me more wiser in terms of how do I treat my patient. So the first important trial that really changed is this new trial, which is the Cape COD trial, which came in 2023, where they looked at hydrocortisone in severe community acquired pneumonia. Now in JAMA 2021, also there was a trial which looked at almost the similar question, which was what is the role of steroids in severe community acquired pneumonia, and there they could not manifest any mortality benefit. They said yes, there is an advantage in terms of treatment and there are less episodes of treatment failure, but they could not document any mortality benefit. This trial looked at that concept, that is there any mortality benefit if you start giving steroids, specifically hydrocortisone, in severe community acquired pneumonia. So there are n number of trials which have happened on this particular research question right from 2005 till date, and almost, as I said, everybody has looked at some or the other option, but they could not document. So some were done in the ward category, some were done in the HDU category, some were done in the overall hospital category, but none of the trials looked at only critically ill severe community acquired pneumonia patients. So this was a multi-center, double-blinded, randomized control trial. 31 French ICUs participated, and this went on for almost 5 years. And all adult patients with the diagnosis of community-acquired pneumonia were enrolled. So in the intervention group, hydrocortisone was given as 200 milligram per day for 4 days. 8 days of total if they met all of the following criteria on day 4, which is a PF ratio of more than 200, breathing spontaneously, and the day 4 SOFA. The day 4 SOFA was less than the score on the day 1, and otherwise the mean duration was for 5 days. In placebo or the control group, same regimen was followed except steroids, a placebo was administered. What they documented was, yes, there is a reduction in the mortality in the hydrocortisone group apart from the treatment reduction in the treatment failure. So this is the only trial as of now which looks at hydrocortisone in severe community acquired pneumonia, which looks as mortality benefit, and they could say there is roughly a 50% reduction in the mortality if you are giving hydrocortisone following their regime. The secondary endpoints when it comes to what is the patients who are not receiving mechanical ventilation, yes, that was better. Patients who are managed more on non-invasive ventilation, that was better. And if you look at the safety outcome, so whenever we give steroids, we are always worried about two things. Is there an ICU-acquired paresis, and what is the incidence of secondary infections apart from the apex infection which the patient had? There was no incidence in increase in the secondary infection, rather they were little less as compared to the placebo group. So they concluded that we found that early treatment with hydrocortisone reduced 28-day mortality among patients who had been admitted to ICU with severe community acquired pneumonia. Now, after this trial, the practice has actually picked up of giving steroids from day 1 itself whenever you are diagnosing this as severe community acquired pneumonia. Before that, people were giving methylprednisolone or other congeners of steroids, but nowadays hydrocortisone has more or less become a practice. Almost it's an year-old trial, but this documents that yes, there is some mortality benefit when you give early steroids. And this is that Cape COD trial which they looked at it. Then another 2 trials about fluids. Now these 2 trials came one after the other, right? The classic trial and the Clovers trial, where they looked at what should be the volume of fluid that you should give in ICU patients in septic shock. Now there is a trend towards giving lot of fluid. There is also a trend towards giving fluids for every hypotensive event that the patient has during that stay. But is there any rationale to do that? So if I look at the classic trial, this was an open label RCT, and roughly 8 countries, 31 ICUs participated, and all adult patients at randomization had to have septic shock. That was the criteria at randomization. The onset within 12 hours prior to screening, the lactate levels of more than 2, and IV fluid of 1 liter in the last 24 hours before screening. So these were the only guidelines, or these were the only enrollment criteria. What they found was that and almost 700 odd patients were enrolled in both the groups. If you look at the fluid volume that was given, so in restrictive category, almost 2 liters, 1700, 1800 ml of fluid as a mean fluid volume was given, whereas in the standard group or the liberal group, almost double the volume was given. When you look at the mortality, there was no change in mortality. And when you look at other outcomes, so whenever you are doing a liberal or a restrictive strategy, you are always worried about more of ischemic or an occlusive events. Are there more ischemic events? Am I causing more AKI in these patients? So there was no increased incidence of any adverse effects, including severe AKI. The days alive without any organ support were also similar, and this trial was very important in terms when we have started saying less is more, specifically if you are looking at a septic shock category. They are a vasodilatory state, they are a leaky capillary subset. So if more fluid you give, you are probably causing more harm. So there is no role of giving fluid boluses for every hypotensive event that this patient has during the course of the hospital stay. And they said that intravenous fluid restriction did not result in fewer deaths, and neither did it cause any further harm. When you look at the Clover's trial, they also did almost on the same fundamental. They also divided patients for restrictive and the liberal category, and here they had a very uh, I would say documented protocol that how much fluid to be given, what do you mean by maintenance fluid, what do you mean by a bolus fluid, and this is how they categorize between the restrictive category and the liberal category. And when they looked at the primary outcomes, they almost had similar findings, that the restrictive category also had similar mortality as compared to liberal. And moreover, the organ failure free days, when we look at the secondary outcome, which is organ support at 28 days, ventilator days, ICU free days, hospital free days, they were more or less similar in both the groups, and there were no other administered, no adjunctive therapies, extra adjunctive therapies were required. And so they also concluded that it doesn't make sense to overload your patients, and these two trials are very important in present critical care practice. Something related to antifungal therapy. Now, there is a dictum of how do you start your antifungal therapy. So whenever a patient of sepsis of unknown origin lands into the intensive care unit, you give higher an antibiotics, right? If this patient has 2 or more organ failures, you suspect that either the patient will be having a gram negative or a gram positive. Now, if this patient has risk factors for immunosuppression, chronic kidney disease on dialysis, liver disease, patients on immunosuppressive therapy, oncology patients, you think probably the patient may also be having a fungal etiology as a cause, and you start certain antifungal agent to these patients, and then you evaluate once the cultures are there. Looking at that front, because in West there is a huge culture of sending 1,3-beta-D-glucan before starting any empirical therapies, very specifically in immunosuppressed patients. It's a dictum. If you look at European and an American based database, they will always send 1,3-beta-D-glucan if you want to start an antifungal, and this is very important if your patient is immunosuppressed. So this study, the Candicept trial in 2022, looked at this aspect, that does it really make sense to send 1,3-beta-D-glucan and then decide should I give antifungal therapy. And this was a randomized trial. 18 ICUs in Germany participated. It went on for 3 years, and 342 patients were finally enrolled. The initial enrollment was almost for 2,500 patients, but once they started deleting the patients who did not meet the criteria, 342 finally landed up in the data. So all adult patients with sepsis of less than 24 hours duration, and there has to be an increased risk for invasive candidiasis, like patients on TPN, abdominal surgery within the last 7 days, more than 48 hours antibiotics within the last 7 days, and patients on CRRT. So they defined very classical what are the risk factors for this category. So they looked at the beta-D-glucan guided group and the control group. So the BDG guided group, first sample was sent, and result was expedited, and within 24 hours the result was there. If the sample, if the result was more than 80 picogram per ml, the antifungals were initiated. And with that more than 80, if your culture was negative, they stopped antifungal. And if they sent 2 BDG samples, which both had the value of more than 80, and even though the culture was negative, they continued the antifungal. This was a protocol for the BDG group. And the control group, the standard care and antifungals were initiated only and only if the cultures were positive. What they found was it did not make any difference in the immunosuppressed or the risk factor group as well. Whether you are not starting an antifungal or you are just starting the antifungal based on your BDG, that the 28-day all-cause mortality was not different. The hospital mortality, length of stay, both in hospital and ICU, The antifungal free survival, yes, it was obviously much higher in the control group because you are selecting the antifungal only based on your culture reports. Time to antifungal, obviously in the BDG group, has to be much earlier as compared to the control group, and the cost of antifungal therapy was almost double in the BDG group. When they looked at from the colonization index, again they did not find any advantage of giving antifungal purely based on the BDG category, and they said early administration of an antifungal therapy guided by serum BDG did not provide any advantage over the standard of care as measured by 28-day mortality among critically ill patients. And this is a very important study because unnecessary rampant use of antifungal just on the premise that yes, my patient is immunosuppressed, it does not make any sense. There has to be solid evidence. Every immunosuppressed patient will not have a fungal infection. We have to understand this. Vitamin C was very famous. Paul Marik came out with a protocol about use of vitamin C in critically ill patients. He somehow showed that there was mortality benefit, and to look at that criteria, the Lovett trial came into the picture where they looked at what is the role of intravenous vitamin C in patients with adult sepsis, and this was the Marik protocol. He gave IV vitamin C at 1.5 grams 6th hourly along with hydrocortisone 50 milligrams 6th hourly and thiamine 200 milligram 12th hourly, and this cocktail was being used in his trial where he showed there was a mortality benefit. So the Lovett trial, this was an international multi-center concealed allocation, blinded RCT, 35 adult medical surgical ICUs in certain part of the Western world were enrolled. It went on for 3 years and almost 400 odd patients were enrolled in both the groups. The vitamin C group received 50 milligrams per kg vitamin C every 6th hourly for 96 hours, and the placebo received similar thing in 5% dextrose. Sorry. What they found was it did not make any difference. Rather, the vitamin C group had little higher mortality as compared to the conventional group. Although it did not reach statistical significance, but still the trend was towards higher mortality in the vitamin C group as compared to the conventional group. Even the organ support requirements was little higher in the vitamin C group, whether that was vasopressor or need for mechanical ventilation or even renal replacement therapy. All the 3 organ failure supports were higher in the vitamin C as compared to the placebo group. The secondary outcomes in terms of the death by 6 months was also marginally higher in the vitamin C, not reaching the statistical significance. If you look at the overall subgroup, when they looked at the forest plot and they categorized these patients based on your age, the gender, what is the clinical frailty score, or what is the severe sepsis score as per the sepsis 3 definition, they found that in most of the categories, placebo group, as in this basic standard of care, did much better as compared to this intervention group. And this is the reason nowadays vitamin C per se as a protocol where you look at severe sepsis is totally out. You don't give vitamin C as a part of your regime. Yes, you can give vitamin C for whatever other reasons you want to give, not as a part of treatment for septic shock category. And they said that receipt of intravenous vitamin C resulted in higher risk of death and even persistent organ dysfunction in 28 days. And this is a very important trial. So if I look at vitamin C related trials, right from 2019, the citrus ALI vitamins, Hibictus, oranges, there were n number of trials, and they either could not show any mortality benefit, or rather it showed that there is an increased mortality benefit. And that's the reason vitamin C is totally out when it comes to the regime of septic shock. Very important trial because it has changed the practice. Now BLINK2 trial looked at what is the role of continuous beta-lactam infusion versus the intermittent one, and after BLINK2 trial we started giving BLIs as a continuous infusion. We started looking at meropenem 3-hour infusion, piperacillin tazobactam as 2-hour infusion. So, and then many observational trials came into the picture from BLINK2 to BLINK3 where they looked at, does it really make sense to give a continuous infusion? So to confirm that fact, the BLINK3 trial was conducted, and this is a very recent publication in 2024 June itself in JAMA. This was published where they looked at what is the difference between continuous versus intermittent beta-lactam antibiotics, and this is the journey of this question, this research question was, it happened in 2015 through Blink trial. Then there were many meta-analysis and randomized trials. Certain surviving sepsis said moderate evidence, and so the Blink 3 was conducted to answer this particular question. Is in the Blink 3 trial, roughly 3,500 odd patients were enrolled in both the two groups, and piperacillin tazobactam or meropenem was used as continuous infusion. What they found was there was no statistical difference between the continuous infusion group and the intermittent group, whether it comes to the clinical cure rate or the all-cause mortality or any new colonization or a new infection in these critically ill patients. The only thing was, yes, the trend was little higher in clinical cure rate towards the continuous infusion, although it did not reach statistical significance, and they concluded that in critically ill patients with sepsis, continuous versus intermittent beta-lactam antibiotics did not significantly reduce the 90-day mortality, and this was the basis on which this continuous infusion came into the picture. So nowadays, frankly speaking, if I have to put it into clinical picture, it doesn't make much of a difference whether you're continuing it for 3 hours, it's a nursing workload, or you're giving it over half an hour to 45 minutes. Yes, the PKPD for meropenem will say T more than MIC. You want to achieve that more than 60% of time frame above the MIC, but none of the trials have actually confirmed the role of giving a prolonged continuous infusion when it comes to beta-lactam antibiotics. So to summarize, there have been various trials which are published in last 2 years, but most of them have not added many huge importance. Yes, there were a couple of previous ones. I did not include that. Only few trials are discussed, have cemented the concept in the present day practice. Applicability in your local unit should always be considered before interpreting the results of any trial. Certain trials I can't extrapolate them in my unit. So yes, they may be good trials, but I'm sorry, I can't inculcate that in my clinical practice. And be wiser and inculcate accordingly in your practice. Thank you so much.
A very good morning. First of all, thank you for the organizing team for organizing a wonderful conference. And second, thank you, Sachin sir, for your articulate insights into nuances of critical care. I would like to throw it to the audience. Any questions for sir?
So, Dr. Sachin, I would like to discuss about liberal versus restrictive fluid therapy. So, in any restrictive fluid therapy strategy, we do not find any mortality benefit, but at the same time, we observe that there is increased usage of vasopressors in those groups, and it always, whenever you give lower fluids, it always translates into higher vasopressors use. So, is it a matter of worry? Do you think that may have an impact on mortality, or may not be mortality, but any deterioration in organ functions? Or what's your take on that?
So, if you look at the concept of fluid resuscitation in septic shock, earlier we used to say, if I have to stick to surviving sepsis, it says 30 ml per kg, give enough fluid. Once your fluid resuscitation has failed, then start vasopressors. Now that concept has gone. You say if your patient is in shock, start vasopressors along with the fluid. Why? Because you don't want to give that amount of fluid. You are able to maintain the map. You are able to preserve the organ dysfunction. You are able to achieve a perfusion for the organs. So the only risk about giving too much of fluids is, yes, you are overloading. You are causing congestion to almost all vital organs. Yes, with restrictive fluid, there will be an increased vasopressor usage. There is no confusion about it. But at least the trials do not show any organ dysfunction along with it. No increased incidence of, I would say, aminases. No increased incidence of AKI. No increased incidence of ischemic events, as in a leg ischemia or other things. So it makes more rational of not pushing too much fluids, specifically in septic shock. They are leaky capillary patients. They will, end of the day, whatever amount of fluid you will give, they will leak out. So you will turn up into anasarca, renal congestion, and other stuff. So we have started reducing the fluids also, and we also believe that vasopressor should be started ASAP. And you can have it through a peripheral line, you can secure your central line eventually, but there's no point in rushing fluids and then thinking of starting vasopressors. No.
Thank you, sir. Thank you so much. Any question from the audience?
Yes, please.
One thing I want to convey is the mortality should not be sole criteria, because all the mortality is very, very hard outcome. But in ICU, you are aware that there are so many things are going on. And with single intervention, nobody can change that outcome.
I
Number
totally
one.
agree that
Yeah.
mortality should never be the criteria, because if I look at mortality, there is no trial which says meropenem saves life, right? And still we give meropenem to every patient, right? So yes, mortality is a very hard determinant, and it depends on 100 variables in a patient. What one should look at, so whenever we read a trial, always look at the secondary outcomes. Don't just stick to the primary outcome. Primary outcomes are done because when you conduct an RCT, if you are not giving a mortality benefit as a primary outcome, the validity of RCT goes down. So you have to put RCT primary outcome mortality benefit. But if you look at the secondary outcome, which are organ failure free days, they are very important in telling was this intervention good or bad. So
Based on this comment only, I am coming back to my question or maybe comment regarding this intermittent versus continuous infusion of antibiotics. So I would suggest, although it seems it is very resource intensive or demanding, still because of pharmacology, as well as this trial also shows some benefit.
yes,
If you say the treatment failure rate at day 14, which is very important outcome, because if somebody don't respond by day 14, then there are more chances that patient going to stay in ICU or hospital for longer time. One thing. The second thing is trials are conducted only on a small population. When you bring the same thing in our population or our practice, where we are treating maybe lakhs of patients, so you can imagine that how much translation of that may be. So that is one point of question. Otherwise, good. Thank you.
thank you.
Yeah. So thank you so much.
Thank you.
Thanks, Dr. Sachin.